Good morning to everyone. Welcome to this new session dedicated on fluid resuscitation. My name is Gianluca Villa. I am an anesthesiologist and intensivist. I work in Florence. Here my co-chair is Stéphane Gaudry. In this session, which is dedicated to fluid overload, we will cover some aspects of fluid responsiveness, nature of fluids. We will cover different part of this topic with important speaker, and just to remain in time, I will introduce Professor Jean-Louis Vincent, which is the first speaker. His presentation is about definition of fluid overload and the meaning of fluid overload. So please.
Thank you very much indeed. So this is a physiological introduction to our discussions this morning. We often use the word fluid overload. This patient has fluid overload. And when I say we, it's perhaps not so much the ICU doctors. It's more the consultants who come to see their patients in our ICU. The surgeon coming saying, oh, my patient is in fluid overload. You gave too much fluid. Or you need to get rid of this fluid. Limit fluid, give diuretics, whatever. I come back tomorrow. Ciao. And yet, for us, it's really essential to understand what we mean. How do you call this? Is it fluid overload? Is it hypervolemia? Is it edema? Oh, clearly it is edema, no doubt about this. But what is fluid overload? What do you do when you have such a question? You go to Google, right? Okay. I found several sentences. You can do it. You will find these sentences right away. Fluid overload is when there is too much fluid in the body. That seems okay. Yeah, I agree. Oh, yeah, sure. Logically. But then fluid overload is also called hypervolemia. Is it the same thing? Fluid overload and increased blood volume? It's when you have too much fluid in your body. It's okay. But fluid overload does not necessarily mean hypervolemia. Hypervolemia, also known as fluid overload, is a condition where we have too much fluid. Same thing. Confusion. Do we need two words, hypervolemia and fluid overload? I will argue that fluid overload is not necessarily hypervolemia. Where shall we go next? Well, to Wikipedia, of course. So Wikipedia, very good. Wikipedia says hypervolemia, not to be confused with volume overload. Very good. Not the same. But just below, they say hypervolemia, also known as fluid overload. Now, to be honest, in between, Wikipedia indicates they don't have enough information and conflicting things. So perhaps you can go and change Wikipedia. Okay. Next step. It's, of course, all together. Yeah, ChatGPT, of course. Confusing. ChatGPT, what is volume overload? I did it yesterday, okay? It's very recent. Well, they refer to circulatory overload. So again, you see a bit of hypervolemia there. And they refer basically to the patient with heart failure, congestive heart failure. Yes, indeed. There is a lot of it on the internet, of course. So it's not too surprising that ChatGPT integrates that type of information. Oh, okay. Instead of volume overload, you could say fluid overload. But, oh no. Fluid overload, also known as hypervolemia or volume overload. We are back to hypervolemia, fluid overload, hypervolemia. It's not the same to have too much water as a whole or to have too much water or fluid in your vessels. So with Michael Pinsky, a few years ago, we wrote this editorial because there was a lot of confusion at the bedside. And we said, the terms hypervolemia and fluid overload are often used interchangeably, yet they do not have the same meaning. Fluid overload may vaguely refer to excessive total body water content associated with edema, but it would be better if the term were avoided completely. The word hypervolemia, the opposite of hypovolemia, means an excess in circulating blood volume, and if present, needs to be properly documented before a strategy of fluid restriction and or diuretics is applied. You may say, well, they're all just terms. Fluid overload is bad, and that's it, you know. No, because our approach may be different. If you look at blood volume, interstitium, so if we have edema, we have an expansion of the interstitial fluid. If there is hypervolemia, there are elevated cardiac filling pressures, left-sided, right-sided, that can favor the edema formation. Like in heart failure, yes, indeed, or in oliguric renal failure. Having high filling pressure doesn't mean that the heart doesn't work properly. It may be hypervolemia if the patient stopped making any urine. But it could be no hypervolemia. We all know that. We have seen patients with anasarca and cardiac filling pressure which are not very high. Think at liver failure. The cirrhotic patient may come with tremendous edema, and when you do your hemodynamic evaluation, you conclude that the cardiac filling pressures are not very high. And in hypoaluminemia, it's not so uncommon to see a patient with edema without increased cardiac filling pressures. Can a hypervolemic patient, a patient with hypervolemia, high blood volume, still be fluid responsive? Yes, of course. Oh yeah. That's called the Frank-Starling relationship. That's what we will discuss again and again and again this morning. Of course, my patient is along one of these lines, and we can easily see that the patient may have edema, may have high cardiac filling pressures, and yet the curve may not have reached the plateau. And that's how we need to do the tests. That's how we need to have to do the fluid challenge in some cases. And indeed, remember, if you want to see some data, remember this old study from Monnet and collaborators and Taboul and collaborators. You have patients with high cardiac filling pressure, central venous pressure, pulmonary artery balloon occluded pressure, who are fluid responsive. That's the R means. So, fluid response, hypervolemia may actually coexist. So, back to my simple slide here, which is the basis of my presentation. It can be very different if we look at tissue perfusion. We had this discussion yesterday in the silver room about the how to use ultrafiltration, how to use diuretics, and we have concluded you cannot give diuretics like that to all patients. There is a bit of edema, add diuretics. Not at all. Because if tissue perfusion is altered, that could be very deleterious. Does edema always mean hypervolemia? No. Indeed, you can be hypovolemic with edema. The presence of edema does not exclude hypovolemia. How come? Well, there are papers describing it for us, but basically, we all know that permeability may be altered in many of our patients. So the hypovolemia may exist, and yet there is passage of fluid in the interstitium. Hypoaluminemia is quite common in our patients and can play, of course, an important role here. And if you like, there are some other interesting mechanisms like lowering of the interstitial pressure associated with inflammatory mediators, NO-induced inhibition of intrinsic lymphatic pumping. You can imagine additional mechanisms, just to tell you that this is not so simple. It's not only hypoalbuminemia. So that's what it is. We can have edema with hypervolemia. We can have edema with hypovolemia. And to continue with my physiologic promenade, we can have an abrupt shift of fluid from the vascular space to the interstitium. Very simply. If I have my myocardial infarction now, I fall here in cardiogenic shock. You bring me to the hospital, you do a chest x-ray, you say, ooh, pulmonary edema. Yeah, pulmonary edema. Edema, you say. But how will be my blood volume? Of course, reduced. Because the water in my lungs, they come from my blood. And indeed, many years ago, Dr. Weil and co-workers did measurements of plasma volume, and it was systematically reduced. But how could it be the case otherwise? I mean, of course, you must have a reduction in blood volume when you have water abruptly going out of the vessels. And that's how in cardiogenic shock, prudent fluid administration is part of the treatment. If indeed someone arrives in the emergency department, acute MI, hypotensive, cardiac output is 4 liters per minute for an average-sized individual, well, you should try to give fluids. You should try a fluid challenge if indeed there is hypotension and the lactate is not there, but let's imagine that the lactate is also increased. So, fluid overload. It's too much fluid in the body. Yeah. Too much water, too much fluid, I don't care. Too much fluid in the body. But where? The patient has anasarca, but develops septic shock. That's the easiest way to visualize the coexistence of edema with a decreased effective blood volume as it is in septic shock. There is vasodilation, so there is, even if you have the same blood volume, it will be too small for an expanded blood space. And there is extravasation of fluids. This patient with COPD may develop septic shock and come to us. Of course, he will have his edema. You will say, oh, that's pre-existing edema. Yeah, sure, of course. That's pre-existing edema. The cirrhotic patient who develops septic shock had anasarca before, but he is admitted in the ICU, and now in septic shock, we will have to give some fluids to this patient. Prudently, fluid challenge, okay, but we still need to resuscitate this patient appropriately. We should not give diuretics to treat septic shock. That's not correct. So that's the slide I presented yesterday. Fluid administration, some egress of fluids in the interstitium, fluid ultrafiltration. Be careful when you remove fluid from the vascular space, because if the capillary refill time does not follow, you may have a transient hypovolemia. It's another physiologic illustration of the potential risks associated with strong ultrafiltration. We may induce some degree of hypovolemia with edema. So the big question is, how is the tissue perfusion? If this is a patient with heart failure and congestive heart failure with lung edema, peripheral edema, normotensive, of course, it's relatively easy. We will give diuretics, definitely. And as our chairman indicated yesterday, maybe more than one diuretics. You may be indeed very dynamic with this approach. But if the tissue perfusion is abnormal, think at cardiac preload, you may have to give an inotropic agent, you may have to increase flow to make sure that the tissues receive enough oxygen. So, an edematous patient may be hypovolemic. That's the essential sentence. So we must be must beware of these terms, hypervolemia, fluid overload. Hypervolemia is probably better defined than fluid overload, but still, it's not always easy to really quantify the degree of hypervolemia or fluid overload. I'm not saying we should use one word versus the other. No, we should think about it. And I myself, I also sometimes use the term fluid overload, but immediately thereafter I say, okay, what do I mean? A little bit like stability, as we mentioned earlier. What do you mean the patient is stable? So during rounds, during our discussions, we need to keep this in mind. Fluid overload may vaguely refer to excess total body water. The word hypervolemia is sufficient to indicate an excess in circulating blood volume. Thank you very much.
Thank you, Professor Vincent, for this presentation. We have time for one or two questions from the audience. Professor Romagnoli.
Thank you, Professor, for the lesson. Sorry. A quick question about hemoglobin concentration. Can we use hemoglobin concentration to better understand the kinetics of fluids we administer to our patients, like in the studies of Robert Hahn? Thank you.
Thank you for this question, which is excellent. Because indeed, if we have a contraction of the blood volume, there should be an increase in hematocrit, or increase in hemoglobin, and an increase in protein levels as well. Of course, there should be less water in the blood. And indeed, when I refer to the old studies of Dr. Weil, yes, indeed, during cardiogenic pulmonary edema, we used to see more of these than today. Acute cardiogenic pulmonary edema, acute pulmonary edema, as we used to say. The hemoglobin level is actually sometimes relatively high. Indeed, being in agreement with this contraction in the blood. And as the patient improves, the hemoglobin level is progressively going down. And actually, it was a topic of research when I was in training. But what do you do with it? Once you have documented this, you say, okay, the physiology works. But you are right that it could be a way to better interpret the hemoglobin level. Again, if I fall down here with my cardiogenic lung edema, you bring me to the hospital. If I have a hemoglobin of 10, you may say, well, it's not too bad, hemoglobin of 10. Well, wait a minute. When I get better, when the fluid comes back into the intravascular space, I know that the hemoglobin level will go down somewhat. So this can bring us to the earlier session on blood transfusions, because now the hemoglobin level may fall to 8.5. And you may say, oh, maybe he's bleeding, or oh, maybe we'll need a transfusion at some point. Think at what could happen in terms of time course of hemoglobin associated with the acute egress of fluids from the vascular space to the interstitial space. So it's actually very interesting to put it in the equation. Thank you.
Thank you very much for this very interesting talk, Professor Vincent. It's a pleasure to introduce the next speaker, Professor Xavier Monnet from Paris Sud University, Hôpital Le Kremlin-Bicêtre. Thank you very much.
Thank you very much, Stéphane. Good morning to all of you. And I disclose my conflicts of interest. First, should we assess preload responsiveness, and should we predict fluid responsiveness in all our patients? And I will speak about the ICU patients. Let's take the example of a patient very early during septic shock, for instance, on pneumonia and ARDS, and the patient is tachycardic and hypertensive. And of course, the first treatment will be fluid administration. And we all know that this induces therapeutic conflict, because we know the inconsistent efficacy of the treatment, but also the possible risk of the patient. And indeed, we all know that the risk, in fact, is to give fluid to patients who are preload unresponsive. And that's the main interest of predicting fluid efficacy, to avoid giving fluid to prelude unresponsive patients. And we know that the risk indeed is of increasing what? The fluid balance. You know that this fluid balance is made of the fluid we give at the beginning, at the resuscitation phase, mainly, sometimes at the optimization, stabilization phases, and the fluid we may remove at the evacuation phases. And indeed, the main goal of detecting preload responsiveness is to detect preload unresponsiveness and avoid giving fluid to patients who do not need fluid. For doing so, as you know, we have today several indices and tests, and we reviewed them with Professor Malbrain, with Professor Pinsky recently in intensive care medicine. Nevertheless, should we use these tests and indices in all our patients? Indeed, these tests are quite time-consuming, and this may be a problem delaying fluid infusion, especially at the very early phase of shock treatment. Some of these tests, as you know, require monitoring cardiac output and sometimes cardiac output monitoring devices that are expensive and invasive. And even more, all these tests are not perfect. Sensitivity, specificity is never 100 and 100%. So indeed, should one assess preload responsiveness in all instances in our patients with circulatory failure? Or are there some patients where detecting preload responsiveness would be more justified than in other patients? First, I think that detecting preload responsiveness is useless at the very early phase of fluid resuscitation. Why? This fluid we give very early, obviously, is aimed at compensating for hypervolemia. Relative hypervolemia induced by venous dilation, by capillary leak, and absolute hypervolemia due to fluid losses. But obviously, initially, hypervolemia is so deep and cardiac preload is so low that the patient works on the very left part of the Frank-Starling curve. And at this place, definitely preload responsiveness is constant. At the very beginning, before the patient has received any fluid, preload responsiveness is very likely constant. And later, when cardiac preload has been increased, and when the patient has displaced rightward on the Frank-Starling curve, then preload unresponsiveness may appear, and at this time it may be justified to assess preload responsiveness. We should not consider a patient in the same way very early before any fluid infusion and a bit later when the patient has received 500, 100 milliliters of fluid. Before detecting preload responsiveness may be time wasting. Okay, that's a bit obvious, but that being said, the next question is, okay, but when should we test preload responsiveness? After which time? We have some data about that, and very interesting data. For instance, from the sub-analysis of the Andromeda shock study, from the patients of this study, they extracted the patients in whom fluid responsiveness was predicted and preload responsiveness assessed, and among them they considered patients who were all preload responsive at baseline. That's the black column at the left side. And very interestingly, you see that 2 hours later, after the initial fluid resuscitation, only 40% of the patients were still preload responsive. And at 4 hours, only 20% of the patients were preload responsive. Preload responsiveness disappears early after shock beginning. Very interestingly, in preload non-responders, preload non-responsiveness persisted, and it's only in a minority of patients that it disappeared and they became preload responsive again. The same in this smaller French cohort. 30% of the patients were still preload responsive 30 minutes after the beginning of shock treatment. So yes, not at the very beginning, but do not wait too much test preload responsiveness early. But obviously, it's not only a matter of time, it may be a matter of volume. And here we must consider something which is practical but very important. Obviously, absolute hypervolemia is not the same in all our patients. And so the initial fluid you give to your patients could not be the same in all the patients. It cannot be 30 milliliters per kilogram within 3 hours for all the patients, because obviously patients are different regarding this absolute part of hypervolemia, fluid losses. It may be small in a patient with pneumonia and ARDS, with septic shock and pneumonia, and much larger in a patient with peritonitis. Obviously, these patients do not need the same amount of fluid. This is what we show in this study. It's not published, be careful, with some colleagues, Rishi, Simone Capio, and Jean-Louis Teboul. Look, the amount of fluid that is necessary for making preload responsiveness disappear. And this volume is obviously larger in abdominal sepsis than, for instance, in pneumonia. And again, that's obvious. Very interestingly, on average, or it's more, in fact, the median, it's 30 milliliters per kilogram on average, exactly the recommendation of the Surviving Sepsis campaign. But you see that it's only a median. And of course, there are patients for whom it's too much and some patients for whom it's not enough. On the contrary, we observe that a bolus of 10 milliliters per kg makes patients fluid responsive for a quite long time. Only a very small proportion of patients become preload unresponsive after a bolus of 10 milliliters per kilogram. And so very practically, I would rather recommend a bolus of 10 milliliters per kilogram, 500, perhaps 1 liter of crystalloid, one after the other, rather than only, and in one time, and within 3 hours, by the way, a big volume of 30 milliliters per kilogram without assessing preload responsiveness early. It's not only a matter of time, but also of volume. Then, of course, the next question is, which tests may we use at this very early phase? And that's the advantage of having several of these tests of preload responsiveness. Especially the mini-fluid challenge and passive leg raising are appropriate because you can do that in patients who are not ventilated. And by the way, they can be assessed with non-invasive techniques. That's convenient for the very early phase when the patient, for instance, is in the emergency department. This study has been conducted in the emergency department in the UK and in the US, and a protocol testing preload responsiveness with passive leg raising tested by bioreactants was compared to standard care. And indeed, this early detection of preload responsiveness led to a lower fluid balance in these patients with septic shock. Non-invasive monitoring may be useful for this purpose, and typically new devices, like for instance, this patch that you put in front of the carotid artery, may help you assess preload responsiveness early in this patient. So yes, not in all the patients, for sure at the beginning. Then preload responsiveness should be tested particularly in patients who are at high risk of fluid accumulation, of too much fluid. I will not say fluid overload. Huh? So fluid accumulation. Yes, okay, but how do we assess the risk of fluid infusion? And here I would like to insist on something, a concept that was to which Jean-Louis Vincent alluded just before. Some authors state that the risk of fluid infusion is linked to preload responsiveness, making the hypothesis of this mirror, of this curve in mirror, you say, of the risk of giving too much fluid. In other words, If my patient is preload unresponsive, it's very likely that fluid will be toxic, that fluid will accumulate. On the contrary, if my patient is preload responsive, the risk of fluid may be very small. I do not agree with this four-quadrant repetition. And by the way, it was just demonstrated in that study that was just published in Critical Care. Venous congestion, whatever the criteria they used, was assessed in preload responsive and unresponsive patients. And you see that the prevalence was similar in preload responsive and unresponsive patients. But that's obvious. A patient may be preload responsive with a high risk of fluid infusion. And that's why we should not only assess preload responsiveness, but also the risk of giving too much fluid. We should assess, in our mind, criteria like the volume of fluid we gave. It's not very precise. Perhaps the PF ratio, it does not directly assess the amount of fluid we gave, but perhaps the VIX score, venous congestion, not sure it's better than the simple CVP that we must measure for this purpose, extravascular lung water if you use thermodilution, etc. And then we should not consider in the same way 4 hours later a patient where CVP is at 10, for instance, lung water slightly elevated and lung permeability slightly elevated, and a patient with a much higher risk of fluid infusion. Yes, assess preload responsiveness in patients at risk of fluid accumulation. Finally, another circumstance where testing preload responsiveness may be useful is when deciding to remove fluid. And indeed, a good way to reduce the fluid balance is to remove fluid at the evacuation, de-escalation phase. But then there is a very practical question. Let's imagine our patient 7 days later, and the patient survived, has improved. He receives no more norepinephrine, but he has received a lot of fluid. And I ask myself, should I remove fluid, for instance, with ultrafiltration because the patient is anuric? Then the question is always the same. How much fluid should I remove? 1, 2, 3 liters, 4 liters? I suggest you test preload responsiveness also for this patient. Why? In that study, we made the very simple hypothesis that if your patient is preload responsive before you remove fluid, preload responsive, ultrafiltration will decrease preload and cardiac output will decrease, and the patient will experience intradialytic hypertension. On the contrary, if your patient is preload unresponsive, he or she may be protected against intradialytic hypertension. Changing preload will do nothing on cardiac output, speaking simply. And indeed, that's not a large study, but you see that preload, the majority of preload responsive patients indeed experienced intradialytic hypertension, suggesting it's another time of the ICU stay where testing preload responsiveness may be helpful. Test preload responsiveness, for instance, do passive leg raising to this patient. If cardiac output increases, oh no, do not remove fluid. The patient may experience intradialytic hypertension. So to conclude, yes, preload responsiveness, but not for all the patients, not at the same time. Likely not at the very early phase, but do not wait too much, and also individualize depending on shock and sepsis etiology. Assess preload responsiveness in patients at risk of fluid accumulation, and likely when you decide to remove fluids. Thank you very much for your attention.
Thank you very much for this very interesting talk. Is there any question in the audience about fluid responsiveness? No? Okay, I have a question. You use different tools to assess preload responsiveness, and you show us that the time is important. These tools are different according to the time, day 0 or day 5, for example?
There is no reason to prefer one over the other just because of time. But some tests are easier to use than other ones. I agree, for instance, that passive leg raising is not very easy to perform. The same for the mini fluid challenge, because you must assess the change in cardiac output very precisely. The easiest tests use the ventilator. Just have to click on a button and look at a screen. And expiratory occlusion test, PEEP test, tidal volume challenge. Nevertheless, the advantage of the first ones is that you can use them even in non-ventilated patients, and that may be useful at the very early phase, typically when the patient is in the emergency department. And I think that we miss many patients especially who stay a quite long time in the ED and where prelude responsiveness likely should be assessed.
Thank you very much. Yes, one question. We have 1 minute. So short question with a short answer. Thank you.
If my patient is not fluid responder, I will not give him any fluid, and when to reassess the fluid responsiveness?
It's a very good question. Very good question. If you look at the sub-analysis of the Andromeda shock study, only a minority of the patients became preload unresponsive and became preload responsive again. Nevertheless, I would test it quite often. Okay, perhaps, 30 minutes in unstable patients at the very beginning, perhaps 1 hour. At each time, you ask yourself the question of giving fluid. Initially, we speak about the initial resuscitation, not 3 days later if the patient survives.
Thank you very much.
Thank you.
Thank you.
Thank you, Professor. Now, I would like to invite Professor Bakker for Columbia University, New York, for his presentation. Being fluid responsive be good for the patient?
Thank you very much for the introduction. Of course, Xavier already used a lot of my slides, but that doesn't make any difference. I will change the perspective a little bit, because fluid unresponsiveness is never a goal of critical care. And for you in the room who is fluid unresponsive at this point, I would go and seek medical help. That's a pathologic state. And I will try to explain later on. I have no disclosures for this presentation. So fluid responsiveness in sepsis or basically any other state. Fluid unresponsiveness is an unphysiological state. A healthy individual is always fluid responsive. In a state of fluid responsiveness, a healthy individual can easily more than double cardiac output without any fluid. You don't need fluid to increase your cardiac output. Even if you go to a blood donation station and you donate half a liter of blood, after that you can easily exercise. No problem. You will still have a very high cardiac output. The confusion is by the qualification of fluid responsiveness in sick patients and being hypovolemic. That's not really true. Hypovolemia, in the context of circulatory dysfunction, is a state of decreased cardiac output due to a loss of intravascular volume that results in a decrease in venous return. And this characterization is not really valid for sepsis, like we showed in the sheep model that we published earlier this year, where we showed that if you give endotoxin to a pig and you immediately give a vasopressor, you increase cardiac output, you have no decrease in regional perfusions or microcirculatory perfusion. Because these pigs are not hypovolemic, they're vasodilated, but with the same total blood volume. So the goal of fluid resuscitation, in general, is to improve tissue perfusion by means of increasing cardiac output. And if you have venous congestion at any state, that's a bad sign. There are now increasing number of studies looking at, for instance, the VEXA score that Xavier already mentioned, where they show that if you have this congestion signal, that's a bad signal, bad for not immediately mortality, but definitely for organ function. So the aim of fluid resuscitation is to solve a clinical problem that is likely to respond to an increase in cardiac output. That's why the reflex treatment of hypotension with fluids in patients who are severely vasodilated is a little bit weird, because it's very unlikely that their blood pressure will increase. And so there are many steps. First, the volume you give should increase venous return. Second, it should result, of course, in an increase in right ventricular preload that should result in an increased right ventricular stroke volume. That should go to the left ventricle, increasing the left ventricle preload, resulting in an increase in left ventricular stroke volume. That results in an increase in cardiac output. And if your total peripheral resistance or your baroreflex doesn't respond, you could have an increase in mean arterial pressure. That's a lot of steps if you want to increase, let's say, blood pressure with fluid. So you have to think about, what am I aiming for? And ultimately, either or, the increase in cardiac output and the increase in blood pressure could result in the improved tissue perfusion, which at the end of the day is the aim of your treatment. Now, in the Andromeda 2 study, we did a little deviation from Andromeda 1, where we actually tried to identify patients that are unlikely to benefit from fluids in a way of increasing blood pressure, increasing perfusion, and that's a patient with a high pulse pressure and a low diastolic blood pressure. That usually characterizes a severely vasodilated state, and just filling up the tank in these patients is less likely to generate a lot of venous return, let alone an increase in perfusion pressure by the increase in cardiac output. And that's why we say, if your pulse pressure is low, you give fluids, you start with fluids, and then you assess fluid responsiveness, because even if you have low pulse pressure, but you're not fluid responsive, it doesn't make any sense to give fluids, because you will never meet your objective. If you have a wide open system that we defined as characterized by low diastolic blood pressure, you start with norepinephrine. And you first squeeze the tank and then fill the tank if it doesn't resolve your problem. So if it resolves your problem, that's fine. But if the increased blood pressure doesn't resolve your problem, you still go back to fluids, and you still do, again, fluid responsiveness. Now, in the previous talk in another session, Shoemaker was already complimented for his work in protocols and deriving, let's say, complex algorithms to treat the patient. But Will had always this very famous quote. I don't know if Jean-Louis remembers, but if you ask Dr. Shoemaker, what should we do? He always responded, fill him up to his eyeballs. And Dennis Edwards from the UK, who was, let's say, promoting this concept, he always said, keep them dry, watch them die. And then, of course, we had Emmanuel Rivers, who gave a lot of fluid in a very, let's say, different population that we nowadays see in emergency rooms. And so the whole concept of fluids was give a lot. And when I was trained as a resident, we filled them up to their eyeballs. And we had patients floating in these beds because they were huge of the volume. We don't see that anymore, but that's what we did in the early days. And as already alluded by Xavier, the chances that you have a fluid responsive patient after you start treating the patient rapidly decreases. As he showed, at 4 hours you have, and 6 hours, and at 8 hours almost no one is fluid responsive, but rapidly within the first 4 hours you are left with only 10% of the patients that are fluid responsive. Now, this fluid non-responsiveness is not only okay, if I give fluids, nothing will happen, the cardiac output won't increase. There is actually harm in being fluid unresponsive, because where are you on your Frank-Starling curve, or whatever curve you will call it, you have, let's say, no effect of increasing preload, but this increasing preload over here is not only a right atrial pressure, it's also post-capillary pressure. It's also a driving pressure pushing fluids out of your system. And so when you're when the right heart is at the flat part of the curve, there's no longer a determination for cardiac output. It will not increase cardiac output anymore, whatever the function of the left ventricle. That's completely irrelevant at that point. If your right ventricle is at the flat part, nothing will happen with fluids. And so this element of pressure associated with the state of fluid unresponsiveness, is probably not okay. If you look at the sub-studies that we did from Andromeda Shock with Eduardo Catan, this published about 3 years ago, in the majority of patients we could assess whether they were fluid responsive or not. This is great. In 82% of the patients, they did a test to assess fluid responsiveness, and 30% of the patients at baseline, after 25 ml per kilo, so not even 30, were already fluid unresponsive. And so the fluid responders and the fluid non-responders received the same amount of fluid pre-study. And so not even the 30 ml, though 30 ml per kilo is probably very wrong. I will show in later data. But if you think about amount of fluid and fluid unresponsiveness, at least in the Andromeda Shock, it didn't make any sense. You can be fluid responsive with 26 and fluid unresponsive with 26. So that doesn't help the amount of fluid. And this is already shown by Xavier as well. If you are fluid unresponsive, the chances you become fluid responsive over the next 8 hours, in Andromeda 1 we did 8 hours, Andromeda 2 is 6, are minimal, very low. So this, let's say, reflex treatment, we have a patient, there is a problem, let's infuse fluids, something that I see extremely often in my New York practice, especially in the emergency room, whatever the problem, it's 30 ml per kilo. So the next thing is, okay, this fluid unresponsiveness defines a state where if you want to solve a problem, the answer is please do not use fluids. The other element of fluid resuscitation is congestion. So this is a recent, very recent study, and we looked at the coexistence of a fluid responsive state and venous congestion signals. Now this is based on the VEXA studies. And there's still a lot of discussion. There are not huge amount of studies on the relevance of VEXAs. But it seems in all the studies that when you have a congestion signal in this VEXA study, that's bad. That's associated with morbidity, not really mortality. And so that's what we did in this study. A multi-center prospective study in 3 medical surgical ICUs in Chile. And we did one measurement. And the question we had is fluid responsiveness or unresponsiveness a marker of venous congestion? Is it related? Because if fluid unresponsiveness is a marker of venous congestion and fluid unresponsiveness is not, then you're good to go. Then you can give fluids if you're fluid unresponsive. So that was the question. Well, the answer is no. You can be congested with fluid responsiveness, you can be congested with fluid unresponsiveness, and you cannot be congested with fluid unresponsiveness. There is no way to predict. And if you look at the fluids, it's even worse. So if you think about, if I give a lot of fluids, I probably are more likely to have a lot of congestion. That's not really true. You can have congestion with only 650 ml. And you can be congested or not, you can be responsive or not responsive that's not related, I will show in the next slide. And there is a difference in CVP because the venous signal is, let's say, brought about by the hydrostatic pressure. And remember, the central venous pressure is not your post-capillary pressure. Come to the presentation of Daniel de Bakker and me on Friday, where I'll show that you can have a CVP of 8, where everybody would be like, okay, that's not too bad. And you have a post-capillary pressure of 23, which clearly inhibits microcirculatory perfusion, in that case of the kidney. So CVP is a downstream pressure, and so always lower than your actual post-capillary pressure. And so you would expect that if you have a congestion signal early, this is early in the cause, so this is not massive capillary leak and a lot of organ edema, this is very early, that you would have another measure of congestion, CVP increased as well. And this is the slide already shown by Xavier. As you can see, if you want to have no venous congestion, then fluid responsiveness assessment is not the way to go. You have to measure it. Because if you have a fluid responsive patient with congestion, the system is also telling you, please don't give me fluids. Whatever your problem, do something else, but don't give me fluids. And so and if you look at the milliliters per kilo, actually, the patient that was fluid unresponsive had a lower amount of fluid infused. So the whole element of liters, or let's give half a liter, let's give a liter and see what happens, is probably wrong. Not in the first presentation. I completely agree with Xavier. That's also in Andromeda 2. You have to give at least a liter before you can enter the study. So at the very first moment, it's probably not very relevant. But after that, it's more, let's say, valuable to look at congestion before you even think about fluids. And that's what Eduardo Cotan and Philip Rolla argued in their papers in the Journal of Critical Care. The fluid tolerance aspect, so prevent the congestion, is probably more important before you go to fluid unresponsiveness. And so the whole concept of fluid responsiveness or adequacy of using fluids or the benefit and harm of using fluids is shifting during treatment and has nothing to do with either the amount of fluids or the state of fluid responsiveness or unresponsiveness. And go to the website, read the paper of Rolla, and especially look in the supplemental material where he has a video explaining the different phenotypes. And part of the Andromeda 2 is a study by the group from Philip Rolla looking at congestion using the VEXA score to see how these, let's say, restoration of capillary refill time affects congestion signals. So fluid responsiveness in sepsis, it's an unphysiological state. It doesn't mean the patient is hypovolemic when you're fluid responsive. The goal is to increase global blood flow, increase cardiac output without congestion, and thus improving tissue perfusion. Even a limited amount of fluid can already result in congestion. And there is no clear evidence that a fluid responsive state is associated with outcomes where the signals of venous congestion are associated with morbidity and mortality. So being fluid unresponsive is not associated with bad outcome, whereas the other one is. When the ultimate goal is to improve tissue perfusion, a signal of congestion should make you rethink. Thank you very much.
Thank you, Professor Bakker. Probably we don't have time for questions or for just one very brief questions for very brief answer.
Very big.
Okay, thank you for your presentation.
Thank you very much. So it's a pleasure to introduce Professor Maurizio Cecconi from Milan and from St. George University of London. Thank you. It's your time.
From Milan, actually. But
Milan.
I was also St. George's. Good morning, everyone. Great to be here. It's great to see so many people in the room, standing, sitting in the carpets, and be here to discuss and talk about hemodynamics. We spent 3 days talking about artificial intelligence, and I have to say one of the nice messages that was coming out was that even with new technology helping us to make decisions, probably it's going to be even more important to have an understanding of physiology, to understand really how we can use this, maybe to spot phenotypes and to understand where we are. And I think when we talk about fluids, fluid responsiveness, fluid loading, and fluid intolerance, overload, well, the data is very clear that if we give too much fluid, probably as with any therapy, this is associated with worse outcomes. But then at the bedside, of course, things are a little bit more complicated, and also we have to remember that the picture that we have and what we do is very dynamic. So my assessment and my idea of treating a patient on the first 2 hours in the emergency department, where I have to salvage this patient and rescue this patient, has to be a completely different mindset than when I'm maybe 2, 3, 4 days down the line, and then I start to see a bit of instability, and I need to think maybe if I would use something different. I think this is very important. This is a key, I think, message that the others were also saying, Xavier and Ian. So in the very first hours, probably, remember the fluids can be very beneficial for our patients, and we should look and use that reserve of responsiveness. But then things get very dynamic, and not every patient is the same. Not everyone will have exactly the same trajectory, so really we need to think on how to individualize our thinking and our way to give fluids to that patient, but also to the different phases of the disease of that patient in that moment. A very quick reminder to everyone on how fluids work, if we are asking the right question. The question should be, does my patient have a clinical problem? Can I increase cardiac output and oxygen delivery by giving fluids? If I answer these questions, then I should probably think about giving fluids. And fluids work if we are able to basically to increase the stress volume and the mean systemic filling pressure. I will go fast here because we can talk about this physiology for 30 minutes. I don't think it's that complicated, and I actually think that we will even see some tools and some variables that in the past we were saying maybe we will not use this anymore, like CVP, maybe coming back, maybe with models and monitoring at the bedside that will help us to interpret dynamic changes in cardiac output and CVP and so on. So Guyton was telling us that if we think about the distribution of fluids between the unstressed volume and the stress volume is that amount of volume in the circulation that basically is generating some stress in the system in a moment of no flow, and that generates the mean systemic filling pressure. How do we move from a pressure to flow? Well, in any hydraulic system, what we need is a gradient, so a difference between two pressures. So the first pressure here is the distribution, is given by the distribution between unstressed and stressed volume in the circulation. And if you think about it, also by the volume itself of the container. So think about also vasoconstriction and vasodilation. I will come back to that later. There is another important pressure, which is the backward pressure from the right heart, so the CVP or the rate atrial pressure. In order to have venous returning, so in order to have blood flow, in order to have cardiac output, because cardiac output and venous return are exactly the same variable at any given time, we're just looking at the physiology from two different points of view, well, there needs to be a gradient between the mean systemic filling pressure and the CVP. And this, to me, is one of the key concepts in Guytonian physiology, is telling us that for any cardiovascular state that they can achieve or they can improve, probably having a lower CVP is better than having higher CVP. Sometimes the CVP is, in a way, the price that we pay to give fluids, but if that is necessary to save a patient, probably we should still do that. Does it work in practice? We demonstrated many years ago that indeed when we give a sufficient amount of volume, it doesn't have to be a lot. With Jean-Louis, we've written recently how we think a fluid challenge could be given at the bedside. Fluid-responsive patients are the ones that are able to increase the gradient for the venous return. The ones that do not respond, it means that if we've given enough fluids, it means that the gradient is not increasing. Of course, at the bedside, you don't have all these graphs, and you always have to ask the question, have I given enough fluids or have I not given enough fluids? Or has the patient responded or not? And so how can we do that? Well, let's bring together the physiology that we've always knew from Frank Starling curves and the venous return curves. We just say that they can only intersect at one point only, so that's where my cardiac output and venous return are the same. If I'm now giving fluids to this patient, not just because it's fluid responsive, but because there is a clinical problem there, and I'm thinking that I want to get the preload reserve to increase cardiac output, if I give enough fluids to increase the mean systemic filling pressure, the mean systemic filling pressure will move up. So this is a new venous return curve. And it means that if I give fluids, I will see an increase in stroke volume. If I'm looking at what's happening to the CVP, this is an excellent response. If I'm trying to solve a physiological problem there, I see an increase in stroke volume, cardiac output, with very little increase or no increase in CVP. This is what I want. This is a good response. What I don't want is to give fluids when I'm already on the plateau part of the French-Sterling curve, or maybe approaching there, because if I give a fluid challenge here, even if it is successful in increasing the mean systemic filling pressure, this patient is not responding to fluids, and we start to see prices. So always look at dynamic variables together. I've been told that this sometimes is too complex to do at the bedside, but actually I think we shouldn't throw away this away. Really, with new monitors, new technology, I don't think this is too complicated to model now, and maybe to have ways to understand if this is what we're seeing. Obviously, I also think that when you're thinking about giving fluids, if you can predict the response, it's always better. It's been great work done by Xavier and Jean-Louis and others here, Michael Pinsky among the first. So if we can predict, and there are different ways of doing it, it is not the scope of my talk today, of course use those tools. But remember also that in real life, sometimes things are a bit different than in what you see in a study. And so there are different situations for which you may not have all the criteria for this test to be very specific and very sensitive. And so if I have a dilemma there now, if I have a very, very sick patient, and I'm not completely sure about what the test is telling me about the prediction of fluid responsiveness, well, maybe in a very early phase, I still want to make sure that I don't take away the opportunity for that patient to get something out maybe of a fluid administration. So how can we do that? I'm a great believer that it's better not to run a lot of maintenance fluids and actually use that opportunity to test your physiology, to test your hypothesis. You don't need to give a lot of fluids. We've done studies showing that around 4 milliliters per kilogram in 10 minutes it seems to be reasonable to do a test that is reliable. If you want to use 3, if you want to use 5, I don't think it makes a huge difference. It's more important to use a technique that you can repeat with your teams, that it's used also to discuss and to understand what's happening at the bedside. So you're giving therapy, but you're also testing your physiological hypothesis here. So when you do this, you should not move the patient, you should not aspirate the patient. I tell my trainees you should not go away. You should really look at how the physiology is changing in front of our eyes. If the cardiac output increases, if it stays up there, how the effect then get dissipated or not. And remember that we also need to understand that our patient sometimes is very sick, and it's difficult to look at changes or to extrapolate changes from one variable to the other. If the blood pressure increases when I give fluids, I don't need a fancy cardiac output monitor to tell me that the patient was responsive. A positive response means that the cardiac output has increased, there was good coupling there, and the blood pressure goes up. I cannot say the opposite in our patient. There's plenty of evidence that I give fluids, maybe the cardiac output will have increased, but if I just look at the changes in mean arterial pressure, I may be completely blind. In a way, fluids in these states, they can act a bit as vasodilator. You recruit the microcirculation, it's a good thing. The cardiac output would have increased, but if I just look at map changes, I would miss that completely. So remember, if I have a sick patient in my ICU that is not improving quickly, I think we need to go for deeper monitoring. Echocardiography, we should do it all the time and repeat this assessment many times, but there are also other devices, continuous cardiac output monitor that, again, if the patient is sick, is not improving quickly, let's do it early and let's see what's happening. But then how do I assess if what I'm doing is right, is it enough, or is wrong? Well, I think that goes back actually to clinical examination. So these are just tools and technology that are helping us to give the least amount of drug, fluids, to achieve an improvement in the clinical physiology of our patients. So always, let's assess the skin. Let's see what's happening there. Let's touch these patients. Let's go. It takes 2 minutes to see if the toe, the thighs, the chest, the arms have a different feeling. That's very, very easy to do. And actually, very nice studies in the past, even some Harry Weil did an important studies on the difference in the temperature between the toe and the chest. Very, very easy to do. These things are telling us that clinical examination can help us to understand what's happening. And what is the correspondent at the level of the microcirculation? If I have a good microcirculation that is well adapted, I will have a good density of vessels, good flow, and so on. When this microcirculation in the state of shock in some districts is actually not as good, then probably the correspondent thinking in my examination there is that the vessel density is decreased, there are some capillaries that are not really well perfused. I don't think you need to use this at the bedside to treat your patients. It's just something to keep in the back of our minds about what we are trying to do when we get things better. And again, clinical examination, we have several windows that we should never miss. The mental window, the respiratory rate, again, the skin, the perfusion, the blood pressure, the urine output, they're all telling us a lot of important information. If I have to complement this, of course, with a blood gas analysis, I always tell my trainees, if you have to choose between an arterial and a venous, choose the venous, because the venous gives you something important, which is the central venous saturation. Again, I know many of you probably are not using this anymore in your practice, but if I have a central line for a sick patient, why wouldn't I look at this variable? It's an important variable. It has been kind of thrown away after a series of randomized controlled trials. The randomized controlled trials were trying to replicate the original study of Rivers in trying to improve SCVO2. But if I look at the baseline characteristics, we talk a lot about phenotypes this day in the world of AI. Mean SCVO2 of 73, 71, and 70, telling us that the targets were achieved at baseline, then clearly this study is not representative of a different phenotype, which are maybe those patients that have a low SCVO2. And so these are important things to look, and SCVO2 is not just one single variable, it's a combination of other variables, and I think this is helping us, our physiological thinking. Is the imbalance due to the fact that we're not transporting enough oxygen? Is it due to the fact that the hemoglobin is not saturated enough? Is it due to the fact that we're consuming too much oxygen? And so this conversation at the bedside are very nice to have. A patient with a septic shock due to pneumonia that is breathing very heavily, putting the patient to sleep in a safe way and removing that work of breathing is part of bringing back the balance between consumption and delivery. But the SCVO2, unfortunately, becomes blind to other parts of the circulation when we go above 70, 72%, and so on. So there may be some parts of our tissues that are shunting, and therefore the arterial blood goes there. There is no extraction of oxygen. This goes back very saturated. Some other areas that are extracting a lot of oxygen, the mix that I detect at the end is a single number that could fool me, but maybe there could be other things that I can look at. So an interesting adjunct, I think, in these cases when patients don't get better quickly is, for instance, to look at PCO2 gaps. So examination SCVO2 and then adding the PCO2 gap, maybe to see if there is something that is telling me that I can still work on fluid responsive and on inotropes to move forward. And just in my last minute, we are talking about fluid responsiveness all the time. Often these patients, they have problem also with vasoplegia. So I was from the very old schools, I was told, try fluids first. Well, try fluids first if we believe that the vascular tone is still maintained. If our examination, if what the patient that is in front of our eyes is telling us that vasodilation, vasoplegia is important, well, I could think of giving fluids, yes, but if the capacity has become so much bigger, why not combining effects? Okay, so I could give fluids and pressors, and the increase in the distribution, the different distribution between stress volume and unstressed volume can still increase the mean systemic filling pressure. This is probably one of the reasons why norepinephrine increases cardiac output. It's partially due to beta receptors, but a lot has to do also with this increase in the mean systemic filling pressure. And this is one of the fastest and more powerful way to buy a bit of time, while maybe in the background we start to fine-tune our fluid management. So if you want to hear more about this, we published this last year. It's a review on the pathophysiology of fluid administration. There are lots of these concepts. And I'm just going to conclude saying, remember, we're giving drugs when we give fluids. So always think about what we want to achieve. I think this is true, and this is what we've learned in intensive care, always to use the least amount of energy to achieve our clinical goal and to have some safety metrics there as well. So give them only if indicated. If we decide to give, if we can predict this better, but if we can decide to give it, then let's use a fluid challenge. Choose the techniques you can read, the ones that we are proposing. I think this is very important to standardize a bit what you do. And let's think more and more, especially in patients with sepsis and vasodilation, that vasopressors and fluids can be used together. And the clinical examination, it's always the clinical judgment what guides our decisions. Thank you.
Thank you very much. Is there any question in the audience? A very short question, about maybe 1 minute.
I have just one question for you. But you presented a lot of data on physiology, which encompass the diuresis, CVP, mean. What are the barriers to put all this information together in a single artificial intelligence mechanism that help at the bedside?
I think the barrier is us, to be fair. I think, now we can start to think about these things. This is what we were discussing these days, with Jean-Louis and others about how can we move artificial intelligence into what we're doing now. But I think it would be a mistake to say, put everything into a black box, and so I don't have to remember anything anymore, and not knowing this physiology. I think this understanding of physiology is going to be even more important. But I am confident, maybe I'm too optimistic, that we will see some of these variables like CVP maybe coming back. We have it in our monitors. Why throwing away the data that is so powerful to look at trends analysis and so on?
So your feeling is positive?
Very positive.
Thank you.
Thank you very much.
So it is now my great pleasure to introduce Professor Pinsky from Pittsburgh University in Pennsylvania that probably will solve some of this problem with this presentation.
Thank you very much, and thank you all for staying this late. We're a little late. These are my conflicts of interest, and basically everything that's listed there are the conflicts are what I'm doing right now. Okay, precision resuscitation. You want to identify a patient who has inadequate blood flow to meet the metabolic demands, and you want to define if their cardiac output can meet it. Do they have fluid responsive? They have decreased vasomotor tone as a function of the heart variable. You can address these things by functional hemodynamic monitoring, asking, is the patient in shock? Are they volume responsive? What is their vasomotor tone? And do they have cardiac reserve? If we simply think about shock, that's a whole area. But in a review we did with Xavier Monnet, we have multiple methods now to look at dynamic parameters to identify volume responsiveness. In the studies that I'm going to show you in animals with severe hemorrhagic shock, we use pulse pressure and stroke volume variation because the animals were on mechanical ventilation. You also can look at the tone of the vasculature by looking at how pulse pressure changes relative to stroke volume. For the same stroke volume, if pulse pressure is less, you have a decrease in vasomotor tone. If for the same stroke volume your pulse pressure is higher, you have an increase in vasomotor tone, and thus looking at the ratio of those two tells you instantaneously how vasomotor tone is changing. And one can use this, as this group did, to wean patients off norepinephrine. If they were normotensive on norepinephrine and the ratio of pulse pressure variation to stroke volume variation, which is called dynamic arterial elastance, was greater than 1, they could wean them to the next level down of norepinephrine, and they did not have hypotension. So there's help on the horizon, which is precise resuscitation. In 2004, I proposed to do a multi-center trial, which we never got funded. But then we got funding just 4 years ago from the Department of Defense to do this multi-center study as a closed-loop autonomous system. Basically, you ask the question, is your patient healthy or not? If they're healthy, have a nice day. If they're not healthy, then you ask, they're in shock, are they volume responsive? 50% of the patients in shock will be volume responsive and 50% will not be. But you don't stop there. You continue with asking the question, are they hypotensive and have decreased vasomotor tone? If the answer to that is yes, they are hypotensive with decreased vasomotor tone and they're volume responsive, you give simultaneously fluids and norepinephrine. However, if they are hypotensive but have normal tone, like a patient who's just quickly bleeding, all you need to do is give volume and the blood pressure will go up. On the other hand, you can have patients that are not vasoplegic and are hypotensive. Are vasoplegic but not volume responsive. Those patients are like your septic shock patient who've given fluid to and they're no longer volume responsive, and they need more norepinephrine. And if everything is wrong, and they're not volume responsive, and they don't have a decrease in vasomotor tone, and they're in shock, the problem is between my two hands. It's somewhere in the chest. I don't know what it is, but they need to have that assessed with echo while you're giving dobutamine. And in our model, we recycle this method every 15 minutes, and the input variables are minimally invasive monitoring as shown here. I'm not going to go through this algorithm except to say that we call the algorithm resuscitation from shock using functional hemodynamic monitoring, refit. So I'm showing you the refit algorithm. What I showed you in that pretty cartoon, this is the computer program definition of the decision tree that one would make to allow the data from the pulse pressure and stroke volume variation and the mean arterial pressure and all the other things to say I need to give volume at this moment, give vasopressors, or wean. You cannot see it, but this paper came out this week in Critical Care Medicine, first author Pinsky. Importantly, there are two subtasks within this. One is the giving of fluid. If you're not volume responsive, at the top shown by a pulse pressure variation less than 10%, you don't give fluids. But more importantly, if you're more volume responsive, the level of volume responsiveness gives a greater amount of volume. So if it's 5 mLs, 8 mLs, or 10 mLs, depending on the level of volume responsiveness. So you're not just giving personalized in terms of giving volume responsiveness, volume to volume responsive patients, you're giving more volume to patients in shock who are more volume responsive. And similarly for the norepinephrine, you start if they're hypotensive, but you do not wean it if they're normotensive and they're on norepinephrine if they have vasoplegia. So you look at dynamic elastance. So these are those data. What you're seeing now is in the paper that was just published in Critical Care Medicine. And this is an example of us hemorrhaging an animal down to a mean arterial pressure of 30, bleeding at about 5 mLs a minute. It takes about an hour. And as you can see on the middle panel, mean arterial pressure, the pressure falls. We then wait 30 minutes to simulate the equivalence of that much time for the people to come. And then we start the protocol with 250 mLs of saline and that of whole blood, which is what a trauma group would do in the field if they were sent to the field. And then we allow the fluids as lines here, or norepinephrine to be given as defined by the protocol, and we do not even look at the pig. We do not even touch it. We just make sure that the pressures that the catheters are in and that the fluid's in the bag. And as you can see, the mean arterial pressure rapidly stabilizes, and even though I'm not using mixed venous oxygen saturation to assess resuscitation, it comes back to normal and lactates go down. When we then ask the question, how good are we relative to an excellent critical care doctor? We did the exact same study. The first study we did, by the way, just to prove the algorithm worked, is we used mixed venous oxygen saturation and mean arterial pressure, and this is the time it took to get to the initial stability where we said, I don't need to treat this animal with anything new for the next 15 minutes. That's how we define stability. When we then used heart rate and mean arterial pressure only, the difference was none, and that we called refit 2. And when we looked at a physician, an expert physician who knew the goals of therapy and had all the treatments there, we were non-inferior to having a critical care physician. So let me rephrase that. Using a closed-loop system that you don't touch is as good as having a critical care physician at the bedside. So we decided if this is true in the hospital, shouldn't it be true in transport? No one has ever taken a closed-loop resuscitation system successfully out of the operating room or laboratory. And we said, why not? So we got approval from all the regulatory agencies, including the FAA, to be able to take animals on transport. And that paper is submitted for publication. But to do this, because this was a Department of Defense grant, they wanted us to use a new model of hemorrhage that was even more vicious than just hemorrhaging an animal down to a mean arterial pressure of 30. They wanted us to shoot the animal in its liver equivalent by doing an uncontrolled hemorrhage in the liver, which we weren't going to shoot, so we used a lacerator to open the liver through and through, 2 cuts, 4 centimeters by 4 centimeter cross through it. The animals, if not resuscitated, would die in 45 minutes to 90 minutes of hypotension and bleeding out. We then waited after the mean arterial pressure fell to 30, which didn't take long, packed the abdomen and waited there for the next 30 minutes because we figured that would be the time it would take for the helicopter or whatever to get to them. And then we started the algorithm. Once the first unit of blood went in, which is 250 mLs, we put them on a gurney and we sent them to transport. And for the next time it took to transport them on the helicopter or in the ambulance to the helicopter, we did nothing but make sure that the systems were working. We did not touch the animal. And after it was done, they came back to the lab and we kept them there without touching the animal for 3 hours. Okay? This is an example of me putting the clamp on the liver of an open animal, a pig in this case. This is what the liver lacerator looks like. It's quite medieval. And this is what the hole looks like in the liver. It's through and through. It cuts through a hepatic artery, portal vein, and hepatic vein as well. And this is when we pack it, just all we do is put a gauze on top of the liver and then rapidly sew up the abdomen. We don't touch it. Okay? This is the first time you've ever seen this. This is an example in the laboratory of us taking a liver laceration. Here's our baseline pressure. We had to do the 2 liver lacerations. You see how rapidly the mean arterial pressure falls. We then wait and then start the resuscitation. This is done only in the laboratory in this example. And after doing it 8 times in the laboratory and keeping the animal alive for 3 hours, even though they needed a lot of fluids and vasopressors because they're bleeding to death, we decided it was time to take this show on the road. And so we did a resuscitation from our animal lab to the helicopter, flew them around and brought them back. And then the second, we took 2 animals in an ambulance, drove them out to a remote hospital where a helicopter was waiting, and brought them back. We had to reconfigure our infusion pumps to make it easy to carry. And this is what the system looks like in the animals, and that's our gurney. This is me. Yes, I did all the surgeries. I'm not going to be doing them anymore because I'm trying to retire from the lab. This is Lisa Gordon, who's the chief technician, and this is the head of the Stat Medevac helicopter that was about to take this pig on a flight. This is us getting in the helicopter, and this is what the pig looked like, which we're hiding you from the face, sitting in there, being totally resuscitated from the time it was started, put on the gurney, taken up in the elevator, and put in the ambulance. Resuscitation was independent of where the animal was. This is an example of what it looks like. And this is the very first animal that has ever successfully been transported and having autoresuscitation that has been reported in the medical literature. What you can see is a liver laceration caused an immediate hypotension. The dotted line is the line it took to get to the helicopter up the elevator. This is the helicopter flight, and this is the time back. The amount of blood was given first, and fluids, and the norepinephrine. Resuscitation was independent of site. And in the second animal, we did a longer flight, and it was just as stable. We then decided to put the animals first in an ambulance and drive them for about 30 minutes to a remote airport and fly them around. This is the very first one. You can see here that he was in the ambulance was causing the infusion of pumps to go, but the mean arterial pressure is stable. The machine disconnected right here because of the transport out of the ambulance, but the algorithm continued. We then flew the animal and brought them back. And in the final case, you see the exact same thing. We put them in the the ambulance here, drove to the airport and flew them. And this one, we flew them for 64 kilometers. This is a demonstration of the flight patterns of the 4 trips. The first one is shown in red. You can see we took the animal and took him on a flight down here. That was equal to about 24 minutes, and we flew 39 miles. The second one was this one up here. We went up north, 36 minutes, and the equivalent of 66 miles. In the other 2, they drove for 30 minutes, 9.2 miles to get to the airport, and one they flew it right back. It took us 12 minutes. And finally, in the one that we took out for that, we put them in the ambulance here and flew them out and flew them back 62 miles in 55 minutes. And in all cases, the animals came back stable with a normal lactate, but requiring vasopressors and fluids. They were able to be sustained for 3 hours in a stable condition, despite the fact they were continuing to hemorrhage and they had a belly, a lot of blood was in it. So in conclusion, functional hemodynamic monitoring guided resuscitation allows for the clear decision rules to be allowed to be put into a closed loop system. It standardizes resuscitation approaches, allowing personalized fluid and vasopressor resuscitation, and importantly, it is useful in remote care. It increases the golden hour to the golden 3 hours, which is a major improvement in resuscitation stabilization. It would be extremely useful to apply such approaches in remote care, austere environments, or if you're having to resuscitate during transport. And speaking of transport, thank you for your attention.
Thank you very much, Professor Pinsky, for this amazing presentation. We have 4 minutes before the end of the session, so we can have some question. I will try to continue the session with one question. What is the timeline of your future research on this very interesting device?
The next thing we're going to do is do the exact same totally autonomous care, but in a drone. So there'll be nothing living in the experiment except the pig. The next thing we're going to do is an open loop resuscitation of human beings in a helicopter. And for that, it's much easier to get FDA approval. And then the next thing after that is closed loop in humans. And we expect to do the drones this year. And towards the end of this year, the open loop resuscitation protocol in our Stat Medevac helicopter fleet.
Thank you very much.
Question?
Yeah, question?
Hello. Assisting to this brilliant session makes me to address a question. We saw that we have a lot of problems when we speak about fluid responsiveness. I'm personally working in this field since many years. And my question for you is today, should we redefine the term of fluid responder or fluid benefit? Because as you see, maybe we should define a fluid responder not only in the terms of increasing cardiac output in a significant manner, but also in improving the tissue perfusion as VO2 lactates on, and also to do not produce harm in our patients. That means congestion, increasing CVP.
So to answer your question, because we have to go and we're going to closing in a minute. So the answer to your question, I agree with you. Fluid response is a functional definition showing that if you give fluids, cardiac output goes up. If you're a fluid responder, it goes up. If you're not a fluid responder, it doesn't. That's what fluid responsiveness means. It in no time whatsoever says that you need fluids or fluids are good for you. To say that you need fluids is a function of the hypoperfusion needing the care. And even if you need fluids, if you have venous hypertension, fluids can be bad. So to answer your question, fluid responsiveness and the need for fluids are separate questions and should always be in the mind of clinicians separately used. As I said many, many years ago, 20 years ago, to the European Society of Intensive Care Medicine at one of these sessions, everyone in this room is fluid responsive right now. I pray none of you are in shock. Just being fluid responsive doesn't mean you need fluids. But if you are in shock and you're hypotensive, then fluids are, and you're fluid responsive, it's a very good thing to do, and it will probably outweigh the risks of the volume at the time. In our study, the major thing that fluid responsiveness resuscitation did was prevent us from giving fluid to the pigs when they were not fluid responsive.
Thank you very much. So we are going to close the session. Thank you to